We're talking about a case from my second year. And so Mr. C is about a 50-year-old guy who was brought in by ambulance after some bystanders saw him slumped down in his car. He was at a bank and somebody watched him walk out of the bank to his car. And then as his car was backing up out of his parking spot, it just sort of like slowly backed into the wall of the bank, which I thought was odd. So they looked in the car, they noticed he was slumped over. They checked on him. He was not responsive. He didn't have a pulse. And so this bystander started CPR and called EMS. In total, he got 2 shocks by EMS. Reportedly, he was in ventricular tachycardia. Also got 2 rounds of epinephrine. And on first pulse check on arrival to the emergency department, he did have return of spontaneous circulation. It's estimated that total downtime was about 20 minutes. He's pretty rapidly intubated for airway protection in the emergency department. And then these are his initial vitals after ROSC. So his temperature is 36.1, his heart rate is 97, blood pressure is 134/93, respiratory rate is 20, and oxygen saturation is 100%. They put his FiO2 at 100% and keep at 5 right after intubating. He is a Joe. He doesn't have an ID on him, and so we don't know anything about his medical history, and no one was with him. He was alone. Any clarifying history questions? If not, you can get 1 test for the event. EKG, love it. Here is his EKG. What do you notice? What is the rate? Great. Irregular, variable, highest about 150. Irregularly irregular, is there a pattern? Agreed, irregular, irregular. Do you see clear P waves? Great. And then what, tell me about the ST segments. We can jump to the obvious portion. What's wrong? Elevated, yeah, where are they elevated? Great. So 2, 3, AVF. Will someone remind me how elevated an ST segment needs to be considered both elevated? It doesn't even need to be that much. It's 2 in what leads? Close. So 2 in some of the precordial, so B2 to B3, but everywhere else it's only 1. So it's clearly more than 1 millimeter or 1 small box of elevation, right? 2, 3, and AVF elevations. If you had to guess a coronary artery that is occluded, what would you guess? Great. So those are your inferior EKG leads. And do you see any depressions anywhere, or do you see elevations anywhere else? Yeah, pretty deep depressions in V2 and V3. And what do you make of those? Great. So deep depressions anteriorly can also be a posterior STEMI. So if this patient only had those findings in V2 and V3, not in 2, 3, and AVF, what could you do to figure out if it's posterior STEMI? Yeah, you can do a posterior EKG. So you can do an EKG on their back. So it's possible that this is a posterior STEMI as well as inferior. And so maybe this person's circumflex artery feeds their, the posterior descending, the inferior artery, as opposed to the RCA. Or it's possible these are just reciprocal depressions. So what are you going to do about this EKG? Great. So you call cards. And they're on their way. While they are coming to the ED to see this patient, he gets a post-intubation chest x-ray. What do you see? Yeah, so there's some hilar fullness here. And what about this makes you think pulmonary edema? What else do you see besides the vascular congestion? Yeah, so this is a portable film. So we can't technically say cardiomegaly, but it certainly looks larger than half of the diameter of the chest, agreed. Yeah, totally agree. You can see some interstitial changes here, going all the way out to the periphery. Maybe some alveolar changes here as well. Okay, ET tube looks good. Yeah, maybe a little high. I don't have a ruler out for this chest x-ray first. Yeah. Great. So maybe there's some pulmonary edema here. So you call cardiology, and they take this patient to the cath lab. And you were right. He has a culprit proximal RCA lesion. They do a successful intravenous ultrasound guided primary PCI with implantation of drug-eluting stent in the RCA. Reperfusion was delayed due to the need to intubate the patient and did a head CT prior to taking him to the cath lab to make sure that he had not bled as the etiology of his arrest, because obviously you have to heparinize in the cath lab so you don't want to worsen a brain bleed. And then notably, this patient had prior stents in this LAD and left circumflex. So again, we didn't know anything about this patient, but clearly has had coronary disease before. His left ventricular end diastolic pressure is severely elevated at 44. What's normal? Like 5 to 10. Yeah, pretty low. So this is like quadruple what is normal. And then his LV systolic ejection fraction is estimated to be 5 to 10%. He's got significant biventricular pressure overload. His wedge is 33. What's a normal wedge? Yeah, 15. So this is really high. And he's got decreased cardiac output and index. His cardiac output's 2.29, cardiac index is 1.26. What's normal cardiac output? Yeah, usually about 5. And what's a normal index? Great. Yeah, 2.5. Okay, so they send him to you in the NICU. And then, so after he arrives, he's off pressors. Briefly, he was on an epi-drip post-ROSC. It was actually hemodynamically stable upon exiting the cath lab. But then an hour later, you get a phone call that his heart rate's 121 and his blood pressure 71/42. He still is unresponsive. His extremities are cool and his pulses are palpably weak. What are you worried about and what do you do? Yeah, cardiogenic shock. Tell me more. Yeah. Great, totally agree. So we know he came in with a primary cardiac event. We know his EF is 5 to 10, very low. He's cool to the touch. He's got pulmonary edema on chest x-ray, and now he's hypotensive. So how do you define cardiogenic shock? How do you diagnose it? Yeah, great. So some clinical features are elevated lactate, low urine output, or markers of hypoperfusion. Those can be present in any type of shock, right? And so you mentioned part of cardiogenic shock is a low cardiac index. What else? Yes, usually yes. Their SVR is high as a compensatory mechanism. Great. How on exam might you determine their SVR? Cool, great. So cool to the touch, especially peripherally. You said this patient is. Right. And so the diagnosis actually requires a decreased cardiac index, so less than 2. This patient has there. SVP less than 80 to 90. After fluids, or that worsens with fluids. And unlike septic shock, which tends to be a little more obvious or well-defined, there are a bunch of different definitions of cardiogenic shock, but some of them are compiled here. This is a review from the AHA from a few years ago, 2018, I believe, but how several different trials have defined cardiogenic shock. But the common denominators are really hypotension and a low cardiac index, plus or minus evidence of end organ dysfunction. So do we think that this patient has cardiogenic shock? I see nods, yes. Systolic blood pressure is in the 70s. It was just in the cath lab. We measured his cardiac index, and it was 1.2. So tell me a little bit about etiologies of cardiogenic shock. And I guess if we think about it with cardiac output is equal to heart rate times stroke volume, what can acutely decrease your stroke volume and give you cardiogenic shock? Great, acute MI. Yeah, which valves? Yeah, usually left-sided dysfunction, acute aortic or mitral regurg. Great, what else? Yeah, so you can have acute isolated right ventricular failure. Yeah, great. Or acute decompensation of an existing cardiomyopathy. What if your heart rate is 2? Yeah, tachyarrhythmias. If your heart's going so fast it doesn't have time to fill, you can feel cardiac shock. And then what can acutely decrease your heart rate enough to be cardiac? Yeah, meds, in particular like beta blocker, calcium channel blocker. What else? Yeah. Great. Okay. We're already pretty certain about the etiology of this patient's cardiogenic shock, right? You know, he had an MI, came in with inferior ST elevations on EKG and went to the cath lab and RCA occlusion. So then let's talk a little bit about what to do now. you have him as your primary patient in the ICU after he goes out of the cath lab and he's acutely hypotensive. Can someone tell me how you think about managing cardiogenic shock? Or like sort of realms, areas you think about? Great, so dobutamine, so you can think about contractility. We'll talk a little bit about inotropes. What else? Great, so patients with cardiogenic shock have increased systemic vascular resistance. We can lower that with medications to try to offload the heart. And then one other big category. Great, so you can think about fixing structural problems, absolutely. Yeah, so oftentimes these patients have an increased preload. If you decrease preload, you can decrease the burden on the myocardium. So contractility, somebody said dobutamine. Great, tell me what dobutamine is. Yeah. Yes. So it does act directly on beta 1, but it acts on one other type of receptor predominantly. What's that other type? Great, beta 2. And the action on beta 1 receptors I mentioned is increased contractility, increased chronotropy. What does beta 2 agonism do? Yeah. So this is a pretty great drug for cardiogenic shock because you get increased contractility and you get vasodilation, so some component of afterload reduction. What else could you use? Anybody done CHF at the university yet? Yeah, what do they often use instead of dobutamine?
No.
Mm-hmm. Do you know how Milrinone works? Do you remember? Yeah, what does that do?
It's needs more calcium inside. Also has a
Great, yeah, so it is a phosphodiesterase inhibitor, and so beta 1, the beta receptors act through cyclic AMP, and so it essentially increases cyclic AMP in the cells, which then increases calcium, increases contractility. Joe, do you have any comments about its action on the pulmonary vasculature? I don't know, it's familiar. Great, okay, I guess it's great. And so what else can you use? These are like the two most classic ionotropes. What was this guy on post-arrest? Yeah, he was on epinephrine, but we can also talk about norepinephrine. Tell me about epi's receptor profile. Alpha activity? Yeah. And wait a minute, beta activity? Beta 1? Yeah. Beta 2? Also, yeah. None of these are acting on vasopressin. How about norepinephrine? Alpha agonism? Beta? a little less. And so what's the problem with alpha agonism in cardiogenic shock? Great, so you're going to further increase SPR, which is one of the things we talked about wanting to reduce. Awesome. So if you had to choose one of these things, which one would you start this patient on right now? Blood pressure 70s over 40s, that weak pulses. Yeah, one of the first two is probably your best option. But I'll tell you, start low dose dobutamine and then his blood pressure is 50s over 30s. Great. So sometimes in the most acute period, you just need to maintain the arterial pressure. And so you need some alpha agonism in addition to the inotropy and chronotropy while you're helping to stabilize this patient and address other issues. So he gets started, his epidrip gets turned back on. He was under dobutamine, but it gets shut off temporarily while, because he became too acutely hypertensive. So then tell me about afterload. How do we affect someone's afterload with medications? What kind of meds can we use? Yeah.
Start in one. It's a little bit better. Oh, the max. But it's also, it's a break, right? You try to do something that there would be toleration. You're basically coding. You need a bridge to stuff. Yeah, we're good. Yeah, that'd be good. The thing is, I guess what we get at is like this guy needs support. And so if you're taking care of particularly somebody
Great. Yes. So he does end up going back to the cath lab. So let's talk about in general cardiogenic shock, these two things, and then we'll talk about bullying. But what can you do in general in cardiogenic shock to decrease afterload? What kind of meds can you use? Yeah. What else? Great. I heard hydralazine, which is certainly true, probably in a patient who is less sick because we can give it orally, but not an IV titratable continuous medication like these two are. One more. Yes, another oral option. One more IV option that you can titrate. Use it more in patients with refractory chest pain. Yeah. And then nitroprusside, dilate arteries or veins or both. Yeah, it actually has action on both arteries and veins. How about nicardipine? Just arterial. How about nitroglycerin? Yeah. Predominantly venous. What's the classic teaching of the problem with nitroprusside? Yeah, great. For patients with renal dysfunction and prolonged use of nitroprusside, you get cyanide toxicity. My understanding is acutely, even in renal dysfunction, if you're going to use it for less than like 24 to 48 hours, it's not too much. Okay. Okay, great. Because oftentimes patients in cardiogenic shock are coming in with renal dysfunction, right? It's one of the things we talk about as a marker of hypoperfusion is AKI diffuse urine output. And then what can you do medically to reduce preload? Yeah, diuresis, isolation. What if that's not working? Great, try more. Escalating doses, agreed. And then as a last resort, you can do like ultrafiltration and studying of severe renal dysfunction. But let's talk about, you start this guy on dobutamine, as mentioned, gets hypotensive, so you turn the epi back on, and his systolic blood pressure is still in the 80s. You also have some nitrite in the room, and you try to turn it on to see if afterload reduction helps, but it just becomes hypotensive again, 50s over 30s. So you call the cath lab, and they take him for a balloon pump. Who can tell me how a balloon pump works? Where does it go? Great. So it goes in the aorta, descending aorta. And then what does it do? Yeah, what's the point of that? Great. So this mainly increases coronary perfusion. And then when it deflates in systole, you create essentially a vacuum, which decreases afterload. Here's an example of two different approaches, one being femoral and one being subclavian. But either way, the balloon pump sits in the descending aorta, as you said, with the bottom right above the renal arteries. So any more advanced thoughts on how a balloon pump works?
It actually doesn't obviously turn that down. It's about 0.5 meters. The work is fantastic work. Like dried black cell factory. Also helps to augment. And the other thing that's really great so much more than ever. The two different approaches. You're not going to see an axillary. That's kind of what the data is. We might see people in person which the axillary.
And then besides a balloon pump, what's another mechanical support device you might see in a patient coming out of the cath lab and cardiogenic shock? Yeah, what's an Impeller? Yeah, so while a balloon pump sits in the aorta, inflates during diastole to increase coronary perfusion, and then deflates the systole to increase or decrease afterload. The Impeller is a little, looks like a pigtail catheter here, sits in the left ventricle. You can see here, blood comes in at this component. And it's essentially like an Archimedes screw that shoots blood from the left ventricle out into the aorta, comes out here. And it can substantially augment the cardiac output. What's the main, what are the main problems with impellers? You can clot. I think more commonly you can get hemolysis. You can mechanically shears red blood cells. Yeah, I was taking care of a patient with impeller. Infection. That's a good question. I don't actually know about infection risk with impeller. Doesn't necessarily augment coronary perfusion as much. And you're getting more forward flow, more cardiac output, so you do better coronary perfusion than you would without an impeller. Yeah, from what? Yeah, you get pigment nephropathy, renal failure from that. They're pretty big too. You get limb ischemia from whether inserted. They're preload dependent. You have to have enough blood in the ventricle. Yeah, which then becomes a problem when you're trying to also do this. Okay, great. Well, let me show you guy's chest X-ray after he goes back to the cath lab. Tell me what devices or lines this patient has now. Yeah, where's the swan? Yeah, great. So it's a swan in his IJ going into his SVC, right atrium, right ventricle, and then extending there into his right pulmonary artery. PA cath or swan dance catheter. What's the point of this? Great, so you can real-time measure cardiac output, SVR, you can wedge it to the pulmonary capillary wedge pressure, invasive hemodynamic monitoring to guide treatment. Awesome. What else does he have now? Yeah, inflated or deflated? Yeah. So is this systole or diastole? Great. What else does he have? Couple more. Yeah. Gastric tube should stay midline in the esophagus and then should force the patient's left under the diaphragm into the stomach. Probably no since he was into it. Great. And then for just teaching purposes, here is what this is a subsequent chest X-ray, but this is what the balloon pump looks like when it is deflated during systole. You can't see the balloon there fully.
How do you know What's that?
If you have an axillary balloon pump, do you have a marker on the other side? Okay. Great. So this patient gets an intra-aortic balloon pump for afterload reduction. Remains on dobutamine for about 24, 48 hours, but can now tolerate it. Is weaned off of all vasoactive agents since balloon pump is removed at about 48 hours. And this guy actually walked out of Denver Health without even going to rehab after cardiac arrest. Amazing. One of the most unstable patients I've cared for that day walked out. One other thing I wanted to talk about that I meant to talk about earlier and I forgot is SCVO2 or central venous oxygen saturation. Can you tell me what this is or why it is useful in evaluating a patient with cardiogenic shock? Great. Awesome. Great. And so you measure it off of what kind of a line? Yeah. So this is the percent of hemoglobin that's bound to oxygen in your central veins. And so usually it's drawn off of an IJ central line that should terminate at the end of the SVC or in the right atrium. What's the difference between this and a mixed venous O2 sat? Where's a mixed venous O2 sat? Not peripheral. Not quite. This one more or less comes from the right atrium. What kind of a line do you need to draw a mixed venous O2 sat? A swan, yes. Where do we say a swan should terminate? Yeah, so you're pulling off the pulmonary artery. What's the difference in the oxygenation of blood in the right atrium versus in the pulmonary artery? What are you missing in the right atrium or in the SVC? Coronary sinus, yes. Yes, exactly. So mixed venous O2 sat is your truly mixed venous blood from the SVC, from the IVC, and from the coronary sinus. But we use SCVO2 often to approximate this because far more of our patients have a central line. Okay, and then Sarah explained this very well, but when you have oxygen coming out of the heart, it should be more or less 100% saturated with blood. And as it goes to the body, oxygen gets extracted by tissues. The way I think of this or sort of dumb it down for myself is cardiogenic shock. Your cardiac output is decreased, and so blood flow is sluggish, and you have more time for your cells to extract oxygen. And so when your blood returns to your heart, a ton of oxygen has been extracted, and so you've gone from 100% down to maybe 40% of your hemoglobin being bound to oxygen. Whereas in septic shock, you have a high cardiac output. Blood is flowing very quickly. There's less time for tissues to extract oxygen. You also have impaired mitochondrial function in sepsis, and so your cells just don't do as good of a job extracting oxygen. And so when the blood returns to the heart, it is still quite oxygenated, still pretty high. So sometimes if a patient comes in shock and you're trying to determine the etiology, it's not as clear as a patient who came in with a cardiac arrest, went to the cath lab and had an acute MI. You can draw a central venous O2 sat off of their IJ, which can be helpful. Not specific for cardiogenic shock. Sarah mentioned hemorrhagic shock. If you're profoundly hypoxic too, your SCVO2 can be low because your arterial oxygen saturation is lower at baseline. But it can be helpful as well.
Yeah, it can be really helpful. So let's say we have a swan in the guy who, with an answer. And he comes out with something. He's pretty sick. And then the next day, all of a sudden, gets and you're basically this is some form of the it had been in the high 50s. Good jump up. Except it's a little more serious. This is a fairly that's fun. Or it ruptured septic. Right? So one of the late, but applications pre-wall rupture, almost ruptured septic. Pretty much observation. So one of the ways that you pick that up that is from the unit, make it listen.
Okay, any other questions about this case about cardiogenic shock? That is a great question.
Yeah, so there's a couple things that we can do. Like, get off the kind of showing you the next thing about doing something else. We talked about it, it was a one that last time, great labs, for a couple hours, probably. A little bit institution dependent. There, I would say here I feel comfortable with first good. But also, it's not a trivial one. There's no other ways to get advanced during conflict, so we have a perfect stroke. That's a bit. That's a complex one. So you need a swarm or at least central access. So cardiac output also equals now. So I think this is also helpful with into, if you're going to go up on the night ride, you can go to that. And, so if your night ride actually drops your pressure more, more than you're actually decreasing. Protopes.
Okay, well, thank you. Have a great rest of your day.